So it's Dr. Usman. I'm the associate professor in medicine. Just tell me that if you are listening me or not. Just type it in that. Can you listen me? Type anyone who is listening, please. Okay, that's great. That's great. So today's topic, because one of our senior registrars, she couldn't come, so she cannot, because are not able to attend the lecture. So I have to come in emergency. So today's topic is about the renal disease. Okay, and it's a book chapter, and I will talk about the renal impairment little bit. So what are the functions of the kidney at your stage? That's the most important. So what are those functions? The functions in the kidneys. There are many. They are the homeostatic functions. There is a maintenance of the acid-base balance. There is the electrolyte imbalance. There is a concentration, osmolality, excretion of toxics, metabolic waste, elaboration of hormones, predominantly erythropoietin 125 dihydroxycalciferol, and the renin. So all these topics, when you talk about the kidneys disease, they are separate topics. Mean you have to give a lecture on each of them. That if you want to talk about electrolyte imbalance, acid-base balance, then what we call it, hormone deficiency, then renin-angiotensin system. So all they have the need a full lecture for that. So the function of the kidney is the functional unit is the kidney. As you know, it's a nephron, which is consists of the glomerulus followed by a long network of tubules. So the diseases of the kidneys, they are predominantly in three ways. One is the physiological way, other is the anatomical way. Anatomical way, if you talk about, then the disease will be involving the arteries, mainly the renal artery or the renal vein. Then will be the microvascular involvement called the glomeruli, that will be calling as glomerulonephritis. Then there will be a renal parenchymal disease, which includes what? The tubules and the interstitial space. So therefore, and it's by the physiological phenomena. And another way, sorry, anatomical phenomena. Then physiological phenomena is the perirenal failure, mean the renal failure which happens when the blood supply to the kidney is compromised, mean before the kidney starts, mean the blood supply or the fluid which will be going or entering in the kidney. So if it's not getting enough fluid, so that is called perirenal. Then is the postrenal. Postrenal will be consisting of the ureter and the bladder and the it is also called the drainage system as well. Then will be a renal parenchymal. In that renal parenchymal, all will be, that is called the renal disease. So in the renal disease, there is a huge list of the causes which can cause the kidney condition. It starts from the dehydration, from all sort of failure, cardiac failure, liver failure, pulmonary failure, and then it will be the obstructions secondary to stones or secondary to fibrosis, then in the bladder, and then will be the renal parenchymal. So there are some manifestations of the renal disease. Most of the patient who present, they present either with the fluid overload or with the dehydration. Means there will be signs of the dehydration or signs of the fluid overload. So therefore, there is a lot of high suspicion includes in this system. So what could be those? That if any person who comes up with signs of hypotension or hypertension, both, has very low blood pressure and very high blood pressure, you need to have a suspicion of kidney disease. So in that, it involves nearly every patient, because there is a multi-system involvement. Systemic diseases like diabetes mellitus, hypertension, heart failure, all sorts of failure, they do affect the kidneys as well. So I will, at your level, I will start with that, because this is the book chapter from the rheumatic disease, but it doesn't specifically for the rheumatic disease. It involves all the conditions. So approach to a patient with suspected renal disease requires a careful physical examination and directed laboratory assessment. Individual with the kidney disease may be asymptomatic, and therefore it depends upon the laboratory test which gives you some information, because the symptomatology for the disease is huge, and it depends upon the constitutional symptoms called uh, weakness, tiredness, fatigue, loss of appetite, then shortness of breath, then bilateral leg edema or unilateral leg edema. Then can be a urinary symptom there, where there can be a frothy urine, there can be a decrease in urine or increase in urine output. Then there can be a burning micturition, there can be a hematuria, there can be a proteinuria. So these are the clues which will lead you to think about the kidney disease. So now what are the manifestations of the kidney disease? They are predominantly two. One is the proteinuria, and second is hematuria, and third will be the what we call it the renal dysfunction. So proteinuria, how will you assess for that? Proteinuria is the most common abnormality in the kidney disease. Means there will be a excessive loss of the protein in the body from the kidneys, and most of the protein it depends upon its albumin or globulin or what sort of that. So normally what happens that if you want to look at the protein, the best test for that is the urine dipstick, or here in Pakistan it is called a urine complete examination. There it shows about the proteinuria. So proteinuria, if someone think about the renal disease, that is also a screening test. Mean if you do a complete urine examination, if it's normal, there is no proteinuria, it means the patient, he may not have at all renal disease, or he may have a very mild renal disease. So proteinuria, it is basically a screening test and very essential and useful tool on the bedside. So as the kidney progress, so proteinuria increases in that. So when the proteinuria is severe, so it presents with the diffuse peripheral edema. So it depends upon the proteinuria. Normally the urine dipstick, what they say, it write down this in the plus sign, that it will be initially, they will on the report, it will come up traces of the protein are 1 plus, 2 plus, 3 plus. So traces mean it will be 10 milligram, then 1 plus will be 20 milligram, then 2 plus will be 100 milligram, 3 plus will be 300 milligram. So it depends upon that how much is the proteinuria present in the kidney. It means he has a from very mild to very severe kidney failure. So heavy proteinuria, what does it mean? It's a suggestive of the hole in the filter of the kidney, that is the glomerular lesion. It is either called, it also called the nephrotic syndrome. So you don't see the proteinuria in nephrotic syndrome. So what happens in the nephrotic syndrome, as you will read in your physiological in the physiology of the books, that there will be a nephrotic range proteinuria and non-nephrotic range, and along with that there will be hypoalbuminemia, then there will be hypercholesterolemia, then there will be edema and the lipiduria. All this will be the nephrotic syndrome. So so it depends upon that. So what when you approach a patient, because I will talk about more clinical, the labs you will study these in the final year. So whenever you come to see a patient with suspected renal failures, what you will be looking at. So most common and the consistent physical finding in that will be the high blood pressure, because it has the cause and effect relationship. It causes the kidney damage as well, and it will be the consequence of the kidney damage. So hypertension is the most common abnormality which you are going to look at in the physical examination. So hypertension is a common consequence of kidney disease, including the glomerular damage and with the autoimmune disorders. It also gives you the clue about the renovascular disease. Among them is renovascular disease. Normally it counts around 10% to 45%, mean nearly half of the cases they have the renovascular disease, some sort of that. Either it can be acute, it can be severe, it can be mild, it can be refractory. So all this is. So it is also the cause of mild hypertension, though it's less than 1%. So blood pressure on the physical examination, always look for the hypertension. What could be the other sign? Other sign will be the anemia of chronic disease, which is called the anemia secondary to renal impairment. So if someone has a anemia and someone has a high blood pressure, always think about the kidney disease. To find out the cause for that, then you have to investigate these patients. So there are if you are approaching a patient for that, so in the history now what will happen, you will ask about the causes for the kidney failure, like the fever can cause the kidney damage, infections can cause, autoimmune diseases can cause, malignancies can cause, stone can cause. So it depends upon on that. So the clue, as I told you, for the physical examination will be the signs of anemia and high blood pressure. Then the most common abnormality which you can find out for the rare causes are the most severe causes for the kidney will be the rashes. So if you get any rash on the body, anywhere in the body, and you want to think about the multisystemic disease, always think about renal failure. Because a lot of these conditions, among them will be the vasculitis, which is the most common cause. Among the vasculitis will be the small vessel vasculitis, it can be a medium vessel vasculitis, and among them, what will be the condition? There will be Wegener's granulomatosis, Hinox-Schönlein purpura, Scherk-Strass syndrome, microscopic polyangiitis. Nowadays, this anti-neutrophilic cytoplasmic and ANCA-associated this glomerulonephritis vasculitis called GPA. Previously, it used to call the Wegener's granulomatosis and cryoglobulinemia vasculitis. So if you want to rule out the most important are the hazardous disease. So always look for the proteinuria and the second one hematuria. So you can see these on the urine complete examination. If there is no hematuria, no proteinuria, don't worry about that. It can be, if it is mild renal impairment, it will not be a serious one at all. So therefore, whenever you suspect a patient a renal failure, so these are the two investigations. As you are in the second year class, so if someone in your neighbor, in your city, in close relative, they are thinking that might be we have the kidney problem or kidney disease, because they are here in the word is used kidney problem. But in medical terminology, we will see that whether this patient has renal impairment or not. The first test which you will ask for that will be the urine complete examination. Search for that if there is proteinuria, or is there hematuria. If there is no hematuria, no proteinuria, be confident that there is no renal impairment at all. Then ask the patient about the drugs, ask the patient about the other signs, for example, shortness of breath, then the signs of chronic liver disease, signs of heart failure, signs of pulmonary failure. All these conditions, they have some symptoms. For example, the chronic liver disease patient will be presenting with the jaundice, will be having ascites, that is fluid in the peritoneum, and will be having leg edema. Heart failure, he will be complaining of shortness of breath, then there will be leg edema as well. So he will be having orthopnea, mean when he will lie flat, he will feel short of breath. So these are the symptoms which you will consider, and then you will go for the test. For the testing, most probably, as I told you, you will ask for the kidney function test. Among the kidney function tests, what we call it is the renal function test. So there is in the renal function test, there are two types of the tests which we do. We measure serum urea level and serum creatinine level. So normally what happens, the serum urea and creatinine, it helps you to decide whether it's a perirenal failure or the renal failure. It may give you post-renal, but it does not give you much clue. Why it gives you a clue in the perirenal and renal, that you will see is there any proportionate rise in the serum urea and serum creatinine, or there is a disproportionate rise. Right. What it means that if someone has a dehydration, or has a reduced blood supply to the kidneys, or going less fluid to the kidneys, so in that condition, urea will be disproportionately up as compared to the serum creatinine. But if someone has a renal renal parenchymal disease, means kidneys damage, not because of the blood supply, it means his creatinine will be up more than the serum urea level. So this ratio is very, very important. Third one, the test which you will confirm it that if someone has the proteinuria, then you are going to measure the protein level for the 24 hours. And nowadays, because it's very difficult to calculate it, and there was a huge problem for the calculation of that. Now they measure the spot urine, serum albumin, and creatinine ratio as well. So these are the tests which normally we do for the kidneys. And if someone gets these proteinuria and someone gets the hematuria, so if someone gets a hematuria, then you will look for the on the top of that the vasculitis. And if someone gets a proteinuria on the top, you will think about the diabetes mellitus and the hypertension. Though hypertension, hematuria may be more common, but proteinuria is more common as compared to hematuria. So if someone has proteinuria, always think about diabetes mellitus and hypertension. So if someone has a diabetes mellitus and proteinuria, if proteinuria is up, it means he has a worsening of the kidney failure. So here it will be, I will show you a, a diagram here. We will talk about this one. So here are the renal syndromes in the rheumatic disease, but it will be in other part as well. That there can be asymptomatic urinary abnormalities are called subacute. Clinical feature can be none. There can be no feature, but there can be a proteinuria. There can be a microscopic hematuria. You will find out whether is it persistent or is it non-persistent. If someone has a persistent, then it may have a nephrotic syndrome. Then there will be a nephrotic syndrome, acute nephritis syndrome. In nephrotic syndrome, what will happen? There will be edema of the legs, and then there will be ascites, and there will be effusions. Effusions mean plural effusion, pericardial effusions. So pericardial effusion, if someone gets a pericardial effusion, along with that the renal impairment, ascites, it means he has a predominantly hypoalbuminemia, which leads to nephrotic syndrome, which leads to hypoalbuminemia, or there can be a renal failure, sorry, cardiac failure or other sorts of failure. So if someone has edema with or without ascites and diffusion and proteinuria more than 3.5 gram per deciliter plus low serum albumin and elevated cholesterol, think about nephrotic syndrome. But if someone has a nephritic syndrome, what will be the clinical feature? There will be reduced urine output, or there can be a discolored urine or fluid retention. But the symptoms which can be over there, these can be constitution, loss of weight, tiredness, fatigue, and these things. So now there is a condition called rapidly progressive glomerulonephritis or subacute glomerulonephritis. All these are there are a lot of nomenclature, main conditions which we call it. So it can be a acute renal failure, chronic renal failure, acute and chronic renal failure, then acute nephritic syndrome, acute nephrotic syndrome, rapidly progressive glomerulonephritis, persistent or subacute glomerulonephritis, then renal vasculitis, then tubulointerstitial nephritis, then chronic renal failure, mild to moderate, chronic renal failure, severe. So all this is the nomenclature which you give. If so, as nowadays in this generation, people they say that he has a renal problem. So renal problem doesn't mean anything. If someone has a kidney disease, you have to label him whether he has a this acute renal failure, acute kidney injury, also called AKI, which is normally used in the clinical notes, or someone has nephrotic syndrome, nephritic syndrome, glomerulonephritis, then interstitial nephritis, renal vasculitis, or chronic renal failure. So always try to find out what could be the reason for this kidney injury. Is it this? So then look at the signs symptom. But if you look at this part here, you see what is the most common one: edema, decreased urine output. Then there is oliguria or discolor. Then systemic symptom. What are the systemic symptoms? Systemic symptoms simply mean signs of anemia, signs of hypertension, signs of failure. But among the most common is the edema and the blood pressure. So these are the things which you will look at, that anyone who present with that. As at the moment we are giving you just the very basic information. Very basic information. We are not going to the detail, because this glomerulonephritis and this nephritic, what is happened at that level, you will learn in the pathology when you will go ahead that. So as I tell that this, we are talking about the kidney renal failure. So the things they evolve as the diseases comes. For example, Nowadays we have a this corona endemic. So there is a new entity coming up in the corona which is causing the kidney damage, and what is in that is the capillaritis. Now they are talking about the capillaritis, that there is the inflammation of the capillaries. So this kidney disease is very evolving all the time. Means there is new information comes up every month, every few months, every year, or every or so frequently. So these are the whenever you are studying a topic, always particularly from the about the kidney disease, think about the glomerulonephritis, about the vascular problem, about the tubular problems, and about the perirenal or the postrenal diseases. So among the laboratory findings, as here is mentioned, is proteinuria or hematuria. Then there will be, as I told you, that there will be a plasma creatinine level, GFR, hematuria, red cell counts, then albumin. So these are the common tests which we normally do. So we look at the protein, we look at the hematuria and the plasma creatinine level. So if someone has a plasma creatinine level, for example, what is the normal one? You can read it. So if someone has a creatinine clearance of around a GFR of around 120, and his GFR goes down to 60. If we compare this one to the other person who has a baseline of 90 and now it has gone down to 40. So one changes from 120 to 60, other is 90 to 40. So who is having more renal worsening? It is the who is having baseline low GFR and it has gone low significantly. So that will give you the clue that who is having the worst renal failure. So always think about the baseline creatinine level. What was it when you will when you will be checking that? And in kidney functions, nowadays there are a lot of algorithms which are present in the Google, and they can give you some information that if you are suspecting someone has a renal impairment and how his kidney functions are going on. So you can calculate through the calculator available on the website about these kidney functions, and you can assess whether it's mild, moderate, or severe. So I was thinking that if I told me that the lecture is from 11 to 12, so I'm not sure I can keep going with that if they will not be disturbing me. Okay, so then the course of the kidney disease is it's persistent or remitting or relapsing. What is persistent? Persistent means that there is a continuous damage. Remitting means there will be a coming and going down. No, sorry, there will be a the disease is resolving, but relapsing will be that again the patient improved and then the disease come back again. So there are few terminology which you will be reading in that: persistent, remittent, or relapsing. Remittent mean it has gone down, mean if the disease has controlled, but relapsing means the disease has flare up. So there is also a remitting and relapsing phenomena together, that the disease is controlled then come back again, then controlled then come back again. So that is called a relapsing and remitting phenomena. So persistent, remitting, or relapsing, or remitting and relapsing together. Then most common cause among the in our society is the post-streptococcal. It presents with the acute episode and it's common in the SLE. Then there is a progress to renal failure. Then there is a persistent disease, rapidly progressive glomerulonephritis. Then what we call it patchy disease as well, generalized disease as well, involving the whole glomerular cell, involving the part of the glomerular. So these are the what we call diseases. Now look at the causes for hematuria. Just one slide. See here, glomerulonephritis and glomerular disease, IgA nephropathy, membranoproliferative mesangiocapillary glomerulonephritis, then mesangial proliferative glomerulonephritis, lupus glomerulonephritis, crescentic glomerulonephritis with renal vasculitis, Alport's disease, renal vascular disease, renal vasculitis, then hypertension, portal vein thrombosis, arteriovenous malformation, renal vein occlusion. So there is a huge list of these things. These are the causes of hematuria. So if you look at that, the list, it's very difficult to remember this list. So what you will do, you will remember few of the common causes for that. I will show you here a graph little bit, just to give you. It will be a relationship of the plasma creatinine and the GFR relationship. So here, what is happening? Here is a plasma creatinine level. Okay, and it's the GFR. It's 50, 100, and 150. So normal range is this one, 100 to 150. This is the steep curve. So if someone has a serum plasma creatinine is going down, his GFR is going down significantly. So like from the 100, it's the 100. Then here is the suppose 60. Here is the what we call it 50. And when it goes below 50, GFR goes below the creatinine goes significantly up. But as creatinine goes down, the GFR is increases. So there is a what we call it curvilinear relationship. It's not a linear relationship. Linear relationship will be like this, but it is a curvilinear relationship. We do see these relationship in the hypertension and other. So it just to give you the clue for that. Now here is another diagram. Because when you come to the clinical medicine, you will see these. What is this one? This is the years of the age, 30, 40, 50, 60, 70. This is the plasma creatinine level, and this is the creatinine clearance. So if someone in the early on, the what we call it is the, and this is about the men and the women. So it's a different everywhere. So as the age goes on, the creatinine clearance it goes down. So it goes down up to the what we call it up to 60, 70, but 65 that goes down stably over the mean we lose at the age of 65 or 70, kidneys function go down anyway. It can be because of disease or not because of the disease, but there are other factors as well which decreases, among them in the hypertension and the diabetes, because they have the more significant effect on this. So these are the curves which you will see it, just to show you about that how the things are going on. So now there are stages of the kidney disease, a clinical plan: stage 1, stage 2, stage 3, stage 4, stage 5. Stage 1 is what at increased risk, who has a with the risk factor, who has the GFR will more than 90. Then screen CKD, it will reduce the what we call risk for that. Kidney damage with normal or increased GFR more than diagnosis and treatment, comorbid slow progression, CKD reduction. Then kidney damage with mildly GFR will be 60 to 89. 30 to 59 it will be again moderate. It severely will be 15 to 29. And if someone has a patient who is on dialysis, he will be having of GFR less than 15. So less than 50 is the cutoff value. 15 to 30 is severe kidney disease, then 30 to 59 is moderate, then 60 to 89 will be mild. But again, if someone has a 90 or above that, it's normal GFR. So you need to make a plan depending upon the condition. So this is about the clinical thing. Then there is a two types of the glomerular, the what we call nephropathy. One is the focal and other will be the focal segmental and the diffuse. So focal will be, if one glomerular, it is segmental 50%, global more than 50%. If there is if segmental, then it can be a focal segmental, and if it can be a diffuse segmental. If they are, because these, how will you decide about that whether it's a segmental and global? It will be decided by on the histology. So on the histology, you will find whether it's a focal or it's a segment diffuse, and if it's a focal, is it a segmental or is it a global? Then if it's a diffuse, is it a segmental or global? So there are four now terminologies: focal segmental, focal global, diffuse segmental, and diffuse global. If someone has a focal segmental, then 50% of the glomeruli will be damaged. But if someone has a diffuse, more than 50%. Again, it's the global. If someone has a more than 50% of the one glomerulus, then it is called a global. But if someone has a whole 50%, the diffuse and the global component more than 50%, it is called diffuse. So this terminology you will understand when you will come down in the connective tissue design. In the clinical medicine, and you will learn over there. Just I will ask them whether the time is up or not. So I think that the time for the lecture was up to 12 o'clock. So you can we can stop the lecture. So before I go, how is everything? How is everything going on? Just type if you have any question. All right, Aruj Fatma and Memuna Akhtar, very good. So okay, do you have any questions? Type it. Any questions? Omal Zara. So any questions? No, Aruj Fatma, no questions, sir. Okay, that's great. Okay, so thanks very much. Okay, so see you soon. So would you like to come back to the college shortly, or you want to go to keep on holidays? Tell me. Are you looking forward to come to the college, or you are okay at home? Gohar Javed, Safa Seher. Okay at home. That's okay. That okay. That's fine. So thanks very much. So I will leave the meeting now. Thanks very much. Okay, bye.